Well, Sanjay, thank you so much. I think after such a wonderful introduction, you can only be disappointed. So buckle up for that. And hello and good evening. Good morning to you in India. Good evening from beautiful, sunny Southern California, where even when it's dark outside, it's still sunny. And it's a complete pleasure to be with you today. I'm going to try to share my screen. We'll see how well I do. We'll see if I can screw this up for everyone. And then we'll go from there. So here we are, sharing screen now. I hope you can see my screen. It looks like you can.
Yes, sir.
And yes, we are now going to take off. So I will just begin by showing you, I think this initial lecture and this entire symposium on PODOCON 2023 is dedicated to looking forward. But before we do that, I'll just look back, and this isn't very long ago. This is just back in the 1950s in the United States, specifically in Los Angeles. This is a hospital that I attend. It's called Rancho Los Amigos. It's kind of a famous hospital in the diabetic foot and in limb preservation. But this is one of the first, what we would now call a prequel to an intensive care unit. I don't know if all of you can see these, but you see the nurses here. They're tending to women and men with polio. That was the pandemic of the time, the COVID-19 of the time, the world scourge of the time. And that led to these, I don't know if you can see them, but these are what are called iron lungs. And these iron lungs ultimately led to further efforts in cardiopulmonary care and what we now call the modern intensive care unit or ICU in any hospital, whether it's in Chandigarh, in Delhi, in Dubai, or in Los Angeles. So this is just looking back to look forward, but I think we'll see a lot of similarities to this when we kind of get back to this at the very, very beginning. And we give away all of our slides. I would just ask you to email me or tweet at me or whatever you like. And I'm happy to give them to you. We just ask you to copy them and make them better and pay it forward. How does that sound? So here's to that. This is what we're going to be talking about. We'll talk about maybe the current state of affairs in tissue repair and wound healing in the diabetic foot. And then we'll talk about maybe the future. And maybe that's the place where we'll have more ulcer-free days, more hospital-free days, like you saw there, and more activity-rich days for all of our patients. And I've already told you that's really what we're discussing, and we're really starting here. But as we sort of start here, let's kind of move on now to a bigger picture, which is still looking backwards before we look forwards. This is even looking back maybe 40 years earlier than that last photograph. And this is Professor von Bergmann, and he is performing the first surgery ever caught on video. And I will share this with you. I actually have lectured at his own university or his own clinic named after him in Potsdam in Germany. But you'll see here now, this is him going to town. This looks like maybe the fourth year medical student. He seems to be so excited to be there. There's Professor von Bergmann. That looks like a fellow. He doesn't know if he is an attending or if he's a resident. Where do I belong? And we see this. This is the nurse. She's very excited that, and she's upset that he's not wearing gloves, but she's over so quickly. That was very fast for this amputation. But the learning point from this amputation, this terrible event, is not that he did it so fast or anything that's happening on screen. It's what's happening to the right of the screen to this person whose head we can't really see it. And, you know, she or he, back in 1901, 120 plus years ago, probably had a better outlook on life than someone right now in and around Delhi or in and around Los Angeles or anywhere around the world with diabetes, having her or his legs off. And that's terrible. And I think I think we can work together as a family, not only as physicians and surgeons and nurses and therapists, but as engineers, as scientists, even as investors and policymakers, to eliminate preventable amputation over the next generation. And even and that's the big goal, I think, from this meeting. But we are making a difference. And I'll just start with a little bit of this before we get into a lot of the good. And you see here, even in places, this is just from a couple of years ago, and this is from colleagues Amadou and coworkers in France. And you can see even in places now over the last decade where there has been a leveling off of high-level amputations in some parts of the world, and this, of course, seems to be rising in almost everywhere in the world. Even when that's happening, we are seeing an increase in the incidence of diabetic foot ulcers. So what we're seeing here is that these, even for places where there are fewer amputations, there are more wounds. So it's just like cancer was maybe in the 1990s, where there started to be fewer cancer deaths per person around the world, but more cancer diagnoses. So the denominator keeps increasing. So this is something that we have to deal with now, time and time again, all around the world, from South Asia through the rest of the world. And if we're trying to discuss this and trying to put a figure to it, and we're trying to describe it maybe to someone that's outside of this room that we're into, this virtual room, we have to somehow maybe put it into a context that everyone can grasp, and that maybe doesn't care so much about this. But let's just do this. Let's just use a clock here. And every second now around the world, someone around the world develops a diabetic foot ulcer. About half of those get infected. About 20% of those infections end up in hospital, which is now why there's an amputation around the world every 20 seconds. And every 20 seconds, we'd like to think that's terrible. And that's something that we can eliminate. And we'd like to say now, ladies and gentlemen, that the time's up for this. And I believe that. And I believe if we work together as a family, we can really affect change. And I think we can bring technology into this, as is maybe the purpose of some of this symposium, to help us with a little bit of team and tenacity to try to affect change and make a difference. So let's look now at these little diabetic foot ulcers that happen now every second around the world. These things turn into big things, which turn into, I think, epidemiologically significant problems, not just for our patients. But, we were looking back a moment ago at the beginning of the modern ICU because of the polio pandemic 70 or so years ago. But maybe what's happened during the COVID pandemic is something similar. We've seen now not the flowering of the hospital unit and the ICU, but really the push toward having to look after patients that couldn't come into hospital. And this led to concepts like this, like a limb preservation center without walls. And this is really someplace, I think, where not only clinicians and our patients, but really where technology can really make a big difference. And this became an entire policy within facilities in the United States. This is from our group and but led by Lee Rogers, who's my old fellow, who's now running things at the UT Health Science Center in San Antonio. And you'll see here that one of the inexorable changes that's happened is that we've moved from a pre-pandemic model of care to a pandemic and maybe even a post-pandemic model of care, where we're moving off-site and maybe to maximize everything that our patients can do at home, or at least out of the hospital. And I think that kind of thing is happening, frankly, all over the world. And I think we can really slowly affect positive change to make a difference here, to really innovate. And I think hopefully that's what's going to be happening. And one of the really cool things that's happened over the last few years in the United States is that we've started this program called the Center to Stream Healthcare in Place, or C2SHIP. You can go to the website there as well. It's really cool. It's designed really to do two things. It's designed to generate new, novel intellectual property to maximize hospital-free days and activity-rich days. And we have 6 universities now, and we're doing everything from spray-on and spread-on skin to wearable robots to passive monitoring to listen to tone of voice to predict self-harm in veterans, to even drone delivery now of dressing supplies. So it's a really cool time to be looking at all of these new technologies that are entering into all of our world now over the next generation. And we'll talk a little bit about that at the end as well, but we're peppering it throughout. But as we're doing this, I think we have to talk about measuring what we manage a little bit better, because we haven't been doing this very well in tissue repair and wound healing. And this is the first thing we'll talk about before we talk about healing the wounds and moving into remission and maximizing the ulcer-free days, as well as the hospital-free days and activity-rich days. But the fact is that we need to measure what we manage better than we are right now. And we have a lot of opportunity to do this together. And I think this is a place where I think India, not just IIT, but places all over India are really leading in this area in thinking about many things. And Sanjay has been doing a lot of this for a really long time as well. And I think many of you know that. But let's look now, not an axis of evil, but an axis of healing. And let me just show this to you. So imagine this is a timeline, and then imagine we have a wound, and there's maybe just a few things that we need to do each time to a wound to get it to heal. And those things are to try to debride the wound after we sorted out the blood flow and the infection. And then we have to promote granulation tissue. And then finally, we have to get to wound closure. And there are many different things that we need to do over a long period of time. We need to debride the wound. We need to protect the wound. We call that pressure offloading. We can use different things like negative pressure wound therapy or biologics, and certain types of cell-based therapies, and even things like flaps and rotational plasties to try to get the wound healed. These are sort of things that we need to do to try to do this. But imagine now if for every place along the line for not only debridement and vascular infection control or granulation tissue and wound closure, imagine now that we had kind of a diagnostic or a theranostic for each one of these things that could tell us if this, then this. Because right now, all we're doing is trying to observe, and I don't think we're great observers collectively. I'll speak for myself. I try my best, but I think that I think we could do a lot better to try to quantify this. So let's first look at the first kind of thing within trying to quantify things like some of the infection and the blood flow locally. Well, it's really, and even size of the wound. And there's so much going on now in India, in the United States, throughout the EU, all over the world. And one of the things we're doing right now, and this is work of one of my students who's now going to become a young plastic surgeon at Georgetown. This is Mark Swerdlow's work, but we now are doing AI-powered kind of staging. We almost have an AI Sherpa now that can be helping us identify and predict the presence and size of wounds. And it's an exciting time because the data are getting more and more promising in this area to where we can quantify the amount of granulation tissue, the amount of slough, and the size of the wound in a predictive fashion. Well, I don't expect you to know who this is, but this is, we again, looking back to look forward. This is one of the godfathers of the germ theory of medicine. This is Louis Pasteur. You see the beautiful beard and the kind of 19th century kind of Dickensian kind of photograph here. But we need to move from all the work that he did and Semmelweis did and Halsted did back in the 1800s and in the germ theory of medicine and move to something a little more modern, like we called it from Louis Pasteur to CSI, to like a crime scene investigation, to where we could be doing more and more cool imaging and molecular microbiology, even at the chair side. And there's a lot happening there right now. Let me just show this to you. This is a tool that's been around now for about 10 years, but it's gotten a lot more data just over the last couple of years. It's very simple. It's just fluorescence imaging. It's black light that's shining onto bacteria. And what you can do is you can see the porphyrins and pyoviridines in both gram-positive and negatives, and also Pseudomonas here respectively. And then what you can do here is you can identify some of these things to predict and do an image-guided debridement. It's really, really exciting. And let me just kind of move in that same category with infections, because, there's something that used to be called critical colonization, something that was somehow critical and you had to act beyond which the person was going to get infected. But that term was really kind of just a creation of industry, and it really didn't mean a lot. And we wanted to move that term from critical to something that was a little more descriptive to what we do in tissue repair and wound healing, moving it more toward chronic inhibitory bacterial load, or CIBL, CIBL, CIBL. And this now, when we use something like that imaging, we can do something that is image-guided surgical debridement. And if you look here, this was just published now with my longtime friends, Tom Serena from Boston and Professor Edmonds from King's in London, one of the real godfathers of a lot of this work. But you see here that we can now look at a wound that may not look colonized, but yet you can see tons of things like staph and strep within the wound that we can then debride away and then move forward toward healing. And you can see here, you might have this chronic inhibitory bacterial load where most of the signs and symptoms, clinical indicators, may be absent initially, but present now. And we can use another set of eyes. And I think there's a lot of work going on in this area that's very, very exciting. And if you think about it, this concept of chronic inhibitory bacterial load is similar to what we did I'm sure there are going to be people talking about peripheral artery disease. We used to call peripheral artery disease, and at a critical point on that, we used to call it critical limb ischemia, but we moved that to call it now chronic limb-threatening ischemia. And that's what we say here. Chronic inhibitory bacterial load is to infection, as chronic limb-threatening ischemia, or CLTI, is to ischemia. And this is, I think, what we're starting to see now for not only for bacterial load, we're sort of marrying it now with peripheral artery disease. So that was the first thing that we're looking for, things like size, things like infection, things that we could measure as a companion diagnostic at the chair side to measure what we manage in terms of modern technological diagnostics. But what about now to look at promotion of granulation tissue or healing and regeneration? Well, there are things we could do here. We can quantify things like I mentioned, like the amount of granulation tissue or slough in the wound. We already talked about that. We can look at inflammation in the area through different types of analytes. And we can look even at something so simple, wound pH, which is literally a litmus test. But we haven't been doing that. And there are all kinds of things that we can be doing in this population to be assessing all of these different enzymes and analytes to try to predict outcomes in this patient population. And it's a really exciting time to be working in this area. I'll share with you one technology from both the UK and from Los Angeles, from the United States. This is from a company called Rockley Photonics, and they've been part of our Center to Stream Healthcare in place earlier, but they had developed the technology. Actually, if you all have a smartwatch or a Fitbit now, you can see that many of them can detect a heartbeat with a red light. But what essentially this now can do is it can give you, it's essentially just a spectroscopy on your wrist, which is astonishing now. And this sort of idea is becoming more and more common now to measure all kinds of analytes, not just oxygenation and heart rate, but things like blood glucose and many other sorts of things. So it's an exciting time to be working into this area. So that's some of the things about measuring what we manage. But what about looking at the most simple, prosaic kind of thing, which is, and I hope during this symposium there will be people talking about offloading, pressure offloading. But let me just show you some of the advances that are happening there right now, thanks not only to our National Science Foundation, but to our National Institutes of Health in the United States. And this is a study that we're doing where we're trying to use new next generation, simple, inexpensive offloading devices, but devices that people will want to wear, and then marrying that with wearables, with inexpensive wearables that could maybe coach better activity and better adherence to offloading. And I'll just show this to you. This is what we call a smart boot. It has an attachment here for a gyroscope. But the more important thing is it kind of looks cool, right? And this is the kind of thing where not just where, most patients, when they get it, when they get a boot or when they get a cast on them, they feel somehow less than before. It's almost a stigma. Whereas now something like this device was designed by a guy named Mike DiTullo, who designed the second and third generation. It was really cool of Air Jordans. And you could see this looks like that. So this may be a device that our patients will be engaged in from the beginning. And then if you attach some smarts to it, maybe then it could give us a little bit more of a promotion to be more adherent. So it'll say, hey, great job, Mr. Smith. You're wearing your device today for 90% of your steps. Or, oh, Ms. Garcia, that's not so good. Maybe that device is sitting next to your easy chair, or it's acting like a doorstop rather than being on your foot. So this dialogue between the doctor, the nurse, and the patient, maybe with an operator standing by, is really an important area to try to promote better care. And every patient, I think, is going to be different. And we don't have time to talk about this, but it's a really interesting area of sort of health promotion and engagement with the patient, where I think we can learn more from people not in medicine, surgery, or engineering, but rather from marketing and advertising. And how do we get people to do what they know they want to be doing, and what we think they should be doing, and in a positive way? And that's a big question to ask. We don't have time to talk about that, but let's now kind of go into just another few things here. I'll show you this before we get into activity monitoring. You will, I'm sure, see this throughout the symposium, but the equation for developing a diabetic foot ulcer is really three ingredients. It's really two, because patients get neuropathy, and then after that we have pressure, and we can play with pressure externally through offloading, like you saw with that smart boot, or internally through surgery or physiotherapy, if you will. We can also play with activity. And we used to not be able to measure activity very well, but we can now. It's getting a lot better, and thankfully a lot less expensive. And we could do that. We could play with activity, and it's really, if you think about it, these wounds that we deal with on a day-to-day basis are really an imbalance of activity and pressure. And if we can bring that imbalance into balance and into sort of harmony, then I think we're going to help people. And I'll just share this with you, because this is one of the first slides that I ever made up, even as a student. This was in the 1980s. This slide should have cracks on it. But I thought way back when that we could maybe dose activity like we dose a drug. If only we could measure activity better, right? Too high in diabetic feet and you get a wound, too low, and you don't get the cardiometabolic benefit. Just like with a drug, too high and you get toxicity, too low and you don't get the benefit of the drug. So, but maybe we can ease people medically, technologically, mechanically, surgically into a little bit better kind of activity, and while we're monitoring them and trying to prevent problems from happening. And if you look here, so this is from Lieberman's lab in Boston, and this is a if you look at a foot, you don't have to have a foot fetish to say that this is a beautiful gait here. It's just in great balance, and it's just really magical when you watch someone move the way they're supposed to, and it's just the epitome of balance, right? The trouble is that our patients, unfortunately, their activity, pressure, their deformity, these things are out of balance. And these are data from 20 years ago already, where we used some of the first wearables at the time. We started using these in the 90s and into the early 2000s. And the wearables that now are almost free used to cost us $5,000 or $10,000 each. I spent so much money on these activity monitors back then, but it actually led to some really interesting information. And let me share this with you. What we found was that our patients didn't necessarily take more steps, the people that re-ulcerated after healing, but what happened was they took more their activity was more variable. So for instance, maybe the patient would be sitting on the couch and would say, "Oh my gosh, I forgot my grandchildren's birthday." So she'll jump off the couch, run to the store, run to the shops, and take more activity between 10:30 and noon than she would normally take in 2 days. And all of a sudden she comes back because she's out of balance with a blister and a wound. That is the variability in activity that we can predict now. And the cool thing is we can put this into something like a dosing regime. I'll share this with you. This is a 10-year-old technology, but we've actually made smart shirts, smart pendants, and many other things that can measure things. It's like an ECG for your life. This is from Bijan Najafi, who hopefully will lecture to you one time. But we can now just give them a simple, this is just a spreadsheet that we can give to our patients, and they can calculate their daily steps based on their previous activity. And it is free to give away to our patients, and it's just great. Let me show you something else that's free that a lot of us do. And here I'll do it right now too. I'll show this to you. Look, we're all into selfies, right? So I'm going to just do this right now. Oh, so I just took a selfie, and I'm going to send that to you, Sanjay. Remind me. But so that is just, solipsistic. It's just navel gazing, right? But what if you could do something virtuous with the selfie? And we've been getting photos. I get photos every day from my patients for years. But we've created something that we call a foot selfie, and like the foot selfie program. And again, this is something that's entirely free. So this is a gentleman. He's a great guy, and he's completely blind. But thanks to one of my students, again, Mark Swerdlow, you see here, he's able to now. He has an app-based unit that can actually take a photograph, and we have an AI-based sort of Sherpa, if you will, that is sitting on the side that can identify problems ahead of time. But we can even do this manually. We will have what we call foot selfie rounds once a week, every Monday at 7 a.m. And we can go through 100 photos. And not a week goes by when we're evaluating where we don't identify something and where we can't predict and stop a hospitalization. And this happens with the resources are so low. It can be done essentially almost free, except for the time of the nurse and the doctor and the patient. So that's really, really exciting. And we're now putting on machine learning models to predict complications, not only when the patient is outpatient, but when they're an inpatient as well, to try to maximize the time they spend outside of the hospital. And that's just this is just for your right brain. That's for your left brain. So let me just share this with you. So these are two of my great mentors. This is one of the real, to speak about a guru, these are two of mine, but this is maybe the guru prime. This is Professor Paul Brand. And Paul was born in India, born in the UK, but spent so much time in India, working with people with leprosy in Vellore. And he, because of treating people with Hansen's, and leprosy, we learned so much about the insensitive limb. And he started using thermometry on these patients very, very early on. And what he said, and this is Professor Brand, and this is Professor Andrew Bolton, and I sort of just carry their bags for them. I don't carry his bags anymore because he passed away about 20 years ago, but what a brilliant man. And let me just share this with you, because Paul, back then, Professor Brand said, wounds will heat up before they break down. And he was right. They will heat up before they break down. And what is so cool now is that these tools to assess this have gotten relatively inexpensive, to the point where we can now use these things for many of our patients. This is an example of something I have in my clinic. I just have it on my phone, and I can just put it on the bottom like a little dongle, and it's just a little FLIR camera. This is expensive, but it's not crazy. It's about $200 US. But some of the other tools now are less than $10, these thermometers that we can have shipped to our patients, where they can start looking at skin temperatures and dosing and dosing activity like they by checking their skin temperature, just as they dose their insulin by checking their glucose. And we can now give people a guideline and a dose to monitor their activity using that calculator that I mentioned before, but giving them the thermometer as the glucose meter, if you will, to identify the problem. And it's just magical, because it's happening and it's working. We can dose people up and down in terms of their activity. And let me just show you a few technologies. This is one that started in the late 2000s from in Boston, and I remember I helped them with their initial elevator pitch in 2008 and 2009. But this is just a smart bath mat, and what it can do now is it can identify hotspots, right? And it can identify, and it can then alert the nurse or the doctor, and it's more importantly the patient, and it can tell them when there's a coming event, and it's identifying problems not hours in advance or weeks or days in advance. That would be great. It's doing it. It's doing it weeks in advance, which is awesome, because now we can get way out in front of this, and it's getting more and more specific. Initially, it was way too hypersensitive, but this data with AI-based algorithms are getting more and more accurate each and every day. And these companies, they will come and they will go, but the concept and the idea of this kind of monitoring is here to stay. These are some ugly looking smart socks that we were playing with over the last 10 to 15 years, led by Bijan Najafi. These were taken over by another young engineer, Ran Ma, and Ran back then thought maybe she could start a whole company based on this. And she had read something we had written back in the 1990s about subscribing to shoes and socks, just like you would subscribe to your mobile phone, your cell phone. And she actually started a company based on this. And then she took this idea to, which is a foot problem, foot stuff, to the largest consumer meeting in the world, the Consumer Electronics Show. It's like the inner sanctum of geeks. And she was going up against virtual reality and augmented reality. And that year, reality socks ended up winning. I can't believe it. It's crazy. And this now, so some of these things that used to be super unsexy are now getting kind of cool and kind of geek-tastic, if you will. So it's a fun time to be watching a lot of this stuff. Now, moving up the body before we finish with the last couple of things. Yeah, this is from my friend Zoltan Pataki's lab. What a great name, Zoltan. And he's in Geneva, or if you're French, Genève. And he's developed really cool insoles that are just basically smart, that can get out of their own way. We've been thinking about tools that could maybe use a shape memory alloy to do something similar, and maybe even have a closed loop system where they could identify a hotspot and then get out of their own way immediately. But this whole idea is very exciting, because this is happening now. And I think a lot of stuff can happen, not just in Geneva or in the US, but I think, frankly, in South Asia, in India specifically, there's so much brain power. I think a lot of this can happen. as well. Just the last couple of things here, you know, um, wearables are fun, but they're getting kind of passé and a little boring. What if we could marry wearables with injectables? And so this is like a thing now. And some of this was started by a friend of mine, Natalie Wisniewski at Profusa, and also led by one of our former residents, Miguel Montero Baker, who's a vascular surgeon. And I'll just share this with you. You can inject just a little tiny hydrogel caplet below the skin, and then ping it with a laser, and you can measure from a distance analytes, things like oxygen, things like glucose, etc. And you can do this in real time. This is a very exciting technology now that's emerging, and we're starting to see this being developed. And let me share with you another thing on the flow side of things. This is just an intelligent blood vessel. This is a technology from a company called GraftWorks. And this technology is just a PTFE, a Gore-Tex conduit. And, you know, once you've done a vascular procedure, you know that the clock's ticking as well. And you'll see here that you want to know when that bypass is going to go down. This just has a little hemodynamic measurement inside of it. And you can pair with this on the back table in the operating room, operating theater, just as you would pair with your Bluetooth headset. And then this is going to be measured at home instead of the patient coming into clinic. And then when one has turbulent flow, that might indicate that that bypass is going down, and then one can take action. Now, this kind of idea, this is just for short segment conduits now, but it's also being used in the upper extremity for fistulas. And soon, I think we could see things like this being used for more complex distal reconstructions. And isn't this an exciting time, right? Where you can assess this kind of idea. And I think the masters of the universe are going to be the women and men that can put all of this together in one big thing that can communicate, where you can have these different disparate sensors communicating with each other in almost like a biological Wi-Fi, like a Bi-Fi, if you will. And this just happened actually today for us. I just heard this in our Center to Stream Healthcare in Places think tank. This is colleagues of ours at Foresight Health, and they have basically just an intelligent home for older patients. And you see here now, you don't just have a smartwatch, you can have motion sensors in the walls, you can have a smart bed, a smart chair, and a depth sensor, which can then give IR measurements to tell, almost like a Kinect on an Xbox, that could tell motion and predict falls. All of these things communicating with one another with a dashboard, alerting the patient, alerting the clinician, alerting the nurse when there's things that can occur. And Mr. Chair, ladies and gentlemen, I will conclude with this by request. I'll just close with this by saying, when I was a kid, I used to play soccer all the way through university, football, and I was a goalkeeper in soccer. And if you're a striker, if you're a forward, and you take 20 shots and you miss 19, you're the hero. But if you're the goalkeeper, and with that same ratio, not so much the hero, right? And so, but I don't know, I found it, I don't know, I enjoyed that job. And I saw this video of a lonely goalkeeper, and it made me crack up. So I wanted to share it with you. So look at this guy. This is not me, but this is just a guy in the goal. And then watch this. So when I saw this, I sort of cracked up, and I thought to myself, man, that's me. Maybe not in the goal so much anymore, but in clinic or in the operating room, somehow looking dumb like usual. What else is new? But still being strangely in position to help. And it made me think of a wonderful quote by the late great aphorist Mason Cooley. And And Cooley said back then, if you position yourself well enough, circumstances will do the rest. And I believe that. I believe that if we put ourselves together, we can make a difference and affect change and help our patients move through the world a little bit better. And I think we can maximize ulcer-free days, hospital-free days, activity-rich days, because I think that's what we all deserve, no matter what our health, no matter what our age. Ladies and gentlemen, Dr. Sharma, thank you so much for putting up with me.